Hey guys, Dr. Sclafani here, the lab assistant for this imaging course. In addition to being a contributing faculty member for the university, I'm also a sports physical therapist for the Cleveland Clinic, Florida at the Parkland location. So these are the three topics we're going to cover today. Hopefully this presentation will add to your ortho and sports knowledge base as we explore the radiographic findings for each of these particular pathologies. So femoroacetabular impingement, or FAI, has become an increasingly hot topic in the ortho sports world. A lot of really great research has come out in the past 5 years or so that has really brought this pathology to light. FAI is a condition in which there is extra bone growth along the femoral head and/or the lateral aspect of the acetabulum. The extra bone formation results in abnormal contact about the hip joint during movement, most notably during flexion and internal rotation range of motion. This can result in changes in the cartilage or labrum over time. So there are three different types of FAI that exist: pincer, cam, and combined. So we're going to dive into each of these individually in more detail. Cam impingement is the result of excess bone growth along the femoral head, which results in a loss of the normal spherical shape of the femoral head. The drawing on the left shows how the hip should normally move. On the right, we see a drawing of a hip with cam FAI, resulting in early contact of the femur with the acetabulum and thus limited range of motion. In pincer type FAI, there is excess bone growth on the acetabular side of the hip joint, resulting in an extension of the bone laterally. The top drawing again diagrams how the hip should normally move. In the bottom drawing, we see how excess bone growth on the lateral acetabulum can result in limited motion and intra-articular implications. We used to think that cam FAI was more common in high school age male athletes and that pincer FAI was more common in females in their 40s. However, more recent research has shown that both types of FAI are common across all demographics. In fact, the majority of patients with FAI will have a combination of both cam and pincer type. One of the easiest ways to spot cam FAI is to look for a pistol grip deformity on an AP radiograph. This is a way to describe the roundedness of the femoral head, likening it to an old flintlock pistol. In the X-ray on the left, we can see the normal concavity that the superior aspect of the femoral head takes that is in stark contrast to the image on the right. Keep in mind that the pistol grip deformity is purely qualitative and is more of an observation when looking at an AP pelvis X-ray. Some studies have attempted to quantify the amount of pistol grip deformity, but there have been too many challenges to come to a decisive conclusion. One of the most common radiographic measurements for cam FAI is the alpha angle. So first, a circle is drawn around the femoral head in a best fit fashion. Then one line is drawn along the center of the femoral head along its narrowest point so that this line intersects the center of this best fit circle. A second line is then drawn from the center of the circle outwardly in an anterior direction to the point on the femoral head where it loses its sphericity. The alpha angle is then the angle between these two lines. So in the bottom picture, we can see how there's this reference horizontal line that goes through the femoral head into this best fit circle. Then we have the actual line that we're going to measure from that reference line that goes outward up into the part where the femur loses some of that sphericity. Most sources will accept an alpha angle between 42 and 50 degrees as normal. An alpha angle greater than 50 degrees is indicative of cam FAI. You can see in the X-ray on the right how a larger alpha angle will result in more of a cam FAI deformity. If the femoral head has a larger cam bump, the second line extending outward from the circle will be more medial, increasing this alpha angle. Another common measurement when assessing cam FAI is the anterior offset. To measure the anterior offset, one line is drawn along the anterior edge of the femoral neck. A second line is then drawn from the most anterior border of the femoral head. The anterior offset is the distance between these two lines and is oftentimes measured in millimeters. So here we can see there's sort of this reference line again along the top. So on the top here as well, that's going to go right along the anterior aspect of that femoral head. Then what we need to do is draw a second measurement line that's going to go near the femoral neck, right as it intersects the femoral head. So most sources will accept any measurement of 10 millimeters or above as normal, while less than 10 millimeters is indicative of CAM FAI. In the X-ray on the right, we can again see how a larger CAM bump will result in a more anterior position of the anterior femoral line, which will result in a smaller anterior offset measurement. CT scans are not routinely taken unless an orthopedist is preparing for surgery. In this labeled image, we use lines numbered 4 and 5 to measure the anterior offset, which is labeled as number 6. We can see again how a larger CAM bump would move line number 4 forward or anteriorly, resulting in a smaller anterior offset measurement. Let's transition now to images related to pincer type FAI. The lateral center edge angle, also called the angle of Weiberg, is oftentimes measured to determine the amount of acetabular overcoverage present. So the first line that we draw is more of a reference line that is drawn from the center of the femoral head straight vertically. Another line is drawn from the center of the femoral head to the most lateral edge of the acetabulum. So the angle between these two lines is then measured. If we look at the hip, if we look at the right hip in this AP pelvis X-ray, we can see how the radiologist measured the lateral center edge angle. So here we have that vertical reference line. We then draw a line from the center of the femoral head out to the most lateral portion of that lip of the acetabulum, and then take the angle measurement between these two lines. Normal values for the lateral center edge angle is reported to be between 25 and 39 degrees. Most agree that angle measurements higher than 39 degrees are indicative of pincer FAI. It's easy to see between these two X-rays how a more prominent lateral lip of the acetabulum will protrude out further laterally, and that will result in a larger center edge angle, as we see in the X-ray on the right. Just to note that lower angle values may be indicative of hip dysplasia, which we won't be talking about today, but you may cover those in some of your pediatrics classes. In a normal AP view of the pelvis, the anterior wall of the acetabulum is always medial to the edge of the posterior wall. A crossover sign occurs when the posterior wall becomes medial to the anterior wall of the acetabulum. If we look at the CT scans and drawings on the right, we can see how different versions of the acetabulum will affect the hip joint. With pincer FAI in the far right image, the overdevelopment of the acetabulum creates a focal retroversion effect, which is why the crossover sign becomes apparent. This is just another schematic explaining the crossover sign. Clinicians oftentimes describe the acetabular overcoverage from pincer FAI as a retroversion, as we see in the right-hand drawing. This retroversion moves the anterior wall laterally, and thus we see the crossover sign. This is an example of what the crossover sign looks like on X-ray. In figure B, the acetabulum does not jut out quite as far, and the anterior and posterior walls seem to run in a more parallel fashion. However, in figure A, the acetabulum starts to jut out more laterally, resulting in a crossing over of the anterior wall laterally. Another radiographic finding that may point you in the direction of pincer FAI is the posterior wall sign. In a normal hip, the center of the femoral head is located medial to the posterior wall of the acetabulum. In pincer FAI, the posterior wall of the acetabulum becomes medial to the femoral head. Remember that acetabular retroversion is associated with anterior overcoverage of the acetabulum. There haven't really been any quantification studies performed on the posterior wall sign, but this again becomes more of a radiographic observation. The last radiographic finding of pincer FAI that we'll be talking about is the ischial spine sign. We've already talked about how the overcoverage of the acetabulum seen in pincer FAI results in retroversion of the hip. Now we can see this effect a little bit more clearly through the protrusion of the ischial spine medial to the pelvic rim. The ischial spine is typically not visible on an AP pelvis X-ray, as in the left X-ray of two normal hips. However, when the hip becomes retroverted in pincer FAI, as in the left hip on the right X-ray, the ischial spine then becomes visible. It's labeled A on the right X-ray. Because the ischial spine is normally not visible, it makes sense that the specificity is quite high. In the Boster study, the author stated that although high correlation was found between anteversion angle measurements by CT and MRI, significant discrepancies in the absolute anteversion number between the two imaging techniques suggest that they may not be interchangeable. So CT scans were found to have higher inter-observer reliability than MRI. However, there was also a significant correlation between CT scans and examination of hip internal rotation range of motion. From a clinical perspective, the findings of this study showed that the diagnosis of excessive femoral anteversion or retroversion should have different thresholds according to whether or not you use an MRI or a CT to make these measurements. In addition, a diagnosis should not rely solely on either clinical exam or radiographic criteria alone. So just be careful about whether or not you use an MRI or a CT scan to take these measurements, because you can't always correlate a CT measurement to an MRI measurement. So here we can see a series of pre and post-op scans. In the top, we clearly see a patient with combined type FAI. The bottom left image, D, shows the patient post-operative CT scan. There have been some great advancements with the use of the 3D CT scan, and in fact a lot of surgeons are now obtaining a CT scan prior to hip arthroscopy, specifically to investigate the amount and specific location of the cam and/or pincer type FAI. Up to now, we've been focusing a lot on bony morphologies. Let's transition now to the acetabular labrum. The most commonly injured aspect of the labrum is the anterior superior portion, which is what we're going to primarily focus on today. Also, remember that just as in other joints that we've looked at, there is a ring of articular cartilage within the acetabulum as well. We touched on this a few slides ago, but MRI remains the imaging modality of choice to investigate any potential labral pathology. MR images can not only more specifically look at the contralabral region, but they can also more specifically look at any potential labral pathology. And also, in addition, MRIs allow us to look to see if there's any other type of pathologies that may be going about in the hip or pelvic region. So when we talk about whether or not to use an MRI versus an MRA, it's still kind of a controversial subject. So this study showed that both are pretty equivocal when it comes to identifying labral lesions. However, an MRA may be more sensitive when looking at the acetabular cartilage, since the injected dye material is able to permeate into the joint space itself a little bit better. One point is to note that the majority of MRIs taken today have a 1.5 Tesla magnet. Some of the newer MRIs are now using a 3 Tesla magnet. Some of the clinicians I work with at the Cleveland Clinic feel that the 3 Tesla MRIs are just as good as an MRA with contrast. We touched on this earlier about how the majority of the labral tears are within the anterior superior region. So this is largely due to the different properties of the anterior superior labrum as compared to the other parts of the labrum. It's sort of the weak spot of the labrum since it has a lower ability to respond to compressive or tensile forces. As with everything we've discussed in this imaging class, you must correlate radiographic findings, especially MRI, with what you're able to investigate clinically. Remember that not all labral tears result in pain, clicking, or clunking. There have been a lot of studies investigating the hip joint in hockey players, so many researchers have investigated the clinical correlation of MRI findings about the hip joint with clinical presentation in this particular population. This slide depicts the normal appearance of the labrum on an MRI. Notice how there are smooth edges throughout the femoroacetabular junction as well as near the acetabular lip. There doesn't seem to be any white signal extending into the area outlined by the circle. This is an example of a labral tear on MRI. The blue arrow or the yellow arrow is pointing to the labral tear just off the acetabular lip that appears to be a white streak extending superiorly. This slide shows a labral tear that is more lateral than the one on the last slide. So the green circle is surrounding a small white circle a little along the lateral lip of the acetabulum, and this represents a labral tear. So this final labral tear appears to be larger than the other two, as it extends more superiorly and laterally. So the labrum is more than just a simple ring that sits in the acetabular socket, so there are different types of labral tears. A lot of clinicians have been comparing hip labral tears more to meniscal tears in the knee rather than the glenoid labral tears that we see in the shoulder. There have been some reported patterns on the type of labral tear seen with a specific type of FAI. With the acetabular overcoverage typically encountered with pincer FAI, there tends to be more thinning, fissuring, and fraying. When we look at labral tears in patients with CAM FAI, we tend to see more of an avulsion type lesion. This makes sense if we think about the aspherical head of the femur jamming and abutting itself into the acetabular rim. Make sure to look at the cartilage of the hip joint, which is circled in the T2 MRI on the left. Notice how the cartilage appears bright on the T2 image on the left, whereas the cartilage appears dark on the T1 image on the right. Both of these images demonstrate normal hip cartilage. These are T1 and T2 weighted MRIs of the same patient. Notice how on the left T1 image there is superior cartilage thinning as well as a labral tear, which is indicated by the blue arrow. When we look at the right T2 image, we can see an acetabular subchondral cyst, which is indicated by the arrowhead lying adjacent to the labral tear. We've been focusing a lot so far on intra-articular hip pathologies. Let's change gears now and talk about a couple extra-articular hip pathologies that you may encounter in the orthopedic and sports world. So one of the first things that I want to talk about is femoral neck stress fractures. And these tend to be pretty tricky to diagnose. A lot of times they get misdiagnosed as FAI or a labral tear or something like that. So they have a very broad, general-based symptom presentation. So the female athlete triad is something that you need to be aware of and on the lookout for whenever you're treating a female patient prior to menopause. So this is something that oftentimes manifests itself in the form of a stress fracture, and most commonly a stress fracture of the femoral neck. Even though femoral neck stress fractures are rare, they are not something you want to miss. They can have serious implications on a patient's orthopedic health if not caught early enough and if they're not managed appropriately. This is a review of the forces placed through the femoral neck. Most of the forces are compressive forces, which are outlined in blue, that occur with weight bearing through the hip and leg. There are some tensile forces that get placed through the femoral neck, most notably through the gluteal musculature, which we'll talk about here in a minute. As we saw on the last slide, both the compression and tensile forces placed through the femoral neck may become pathological and result in either a compression-sided or a tension-sided femoral neck stress fracture. Most femoral neck stress fractures are the compressive type. In this type of stress fracture, forces applied to the femoral neck exceed the elastic properties of the bone and outpace the normal healing response. Microfractures then develop and propagate at 45 degrees to the application of these compressive forces, which creates an oblique type fracture line across the inferior aspect of the femoral neck. The fracture line created from a compression stress fracture is more oblique than that of a tension-sided stress fracture and is thus likely to displace. Therefore, these types of stress fractures are treated with conservative treatment and with us in physical therapy. The caveat is that these types of stress fractures are stable until the fracture line traverses greater than 50% of the width of the femoral neck, and then it has a higher chance of becoming displaced. This then becomes an emergency surgery situation. Tension-sided femoral neck stress fractures arise along the superior aspect of the femoral neck. Normally, the gluteus medius and minimus muscles are able to counterbalance the force placed on the superior aspect of the femoral neck. However, when these muscles fatigue, high tension forces develop, resulting in microfracture formation and propagation. This particular fracture line propagates at 90 degrees to the broken cortex, creating a more transverse fracture line. This is inherently more unstable than that of a compression fracture and has a higher likelihood of displacement. Therefore, these fractures are typically treated with immediate surgery. Plain radiographs are routinely performed in any athlete who presents with exercise-related hip or groin pain that is exacerbated by weight bearing. The AP pelvis is usually performed to investigate any osseous abnormalities about the entire hip or pelvis area. In about 2/3 of patients who have a femoral neck stress fracture, there are no changes present on X-ray. It can take about 6 to 8 weeks before stress-related changes are visible on plain film. When there are changes present on X-ray, there will be a periosteal and endosteal callus formation, a sclerotic linear region traversing the primary trabeculi of the femoral neck, and a radiolucent fracture line. MRI is now the gold standard second-line imaging investigation for femoral neck stress fractures. In the study by Shin et al. Out of AJSM, they reported 100% sensitivity and specificity of an MRI to detect a femoral neck stress fracture, although they were specifically looking at endurance athletes. When looking at a T1 MRI, such as the one on the left, there will be a diffuse, ill-defined, rounded, hypointense area about the femoral neck. When looking at a T2 MRI, there will be an equivalent hyper-intense signal in the same area. Remember that normal bone appears dark on a T2 image, making any osseous pathology light up pretty easily. An MRI can also be useful to investigate for any other pathology around the hip and pelvis region, such as a stress fracture in another area or any muscle or tendon injuries. Bone scans are rarely used to investigate a femoral neck stress fracture due to the advancements that MRIs have had. There have been reports of false positives as high as 32% for this particular pathology on a bone scan. In addition, bone scans subject patients to radiation, which is no longer worth the risk given the superiority of MR images. On this bone scan, you can see how there is reuptake present along the femoral neck, and it appears to be along the inferior aspect, suggesting a compression-sided stress fracture. However, given the clarity of MR images that we've looked at previously, it's easy to see why bone scans are starting to be used less frequently for this particular pathology. So this is a nice summary table of what we talked about so far with regards to how femoral neck stress fractures are managed based on the type of fracture and progression. Remember that most of these stress fractures are of the incomplete compression type and are therefore managed conservatively. Most of the other fractures are managed operatively. When it comes to surgical management of femoral neck stress fractures, there's a few implants that the surgeon may choose to use. The last hip pathology I want to talk about is osteitis pubis. This is a tricky diagnosis and it's extremely difficult to treat. There is controversy in all sectors of medicine regarding this particular pathology and is one of those diagnoses that is oftentimes missed and treatment is oftentimes mismanaged. In essence, osteitis pubis is simply an overuse injury about the pubic symphysis and the pubic bones themselves. The name can be slightly misleading as it's typically not an acute injury or itis that will cause the patient to seek medical treatment, but rather a chronic overuse pathology. Although osteitis pubis is most commonly seen in athletes, this diagnosis is not unique solely to the athletic population. There have been numerous terms thrown around for athletes that experience groin pain, so please be sure to use the correct terminology. The majority of publications on osteitis pubis focuses on athletes, primarily those who participate in agility and kicking sports. When we think about some of these movements, it's not hard to imagine how some of these biomechanical forces might become pathologic to the pelvis, resulting in a chronic overload stress injury. The pubic symphysis is exposed to heavy compression loading, strong shear forces, and large torsional forces in many sports, especially while cutting or kicking. Let's review some of the anatomy around the pubis and the pubic symphysis. The adductor longus and the rectus abdominis muscles attach opposite to each other along a fibrous aponeurotic plate between each pubic tubercle across the midline of the pubic symphysis. This aponeurotic plate aids in stabilizing the anterior pelvis. Even though there are numerous tendinous attachments to the anterior pubis, as shown here, the most important for anterior pelvic stability is the adductor longus and the rectus abdominis. Note the opposing vector pull of the adductor longus and the rectus abdominis muscles. Dysfunction in one muscle can have a disruptive implication on the opposing pull, thus creating sort of a tug of war, the pubic symphysis and or the pubic bones themselves. Here we see a sagittal plane view of the pubic ramus, and you can see the tie-in of the rectus abdominis to the aponeurotic plate that also blends in with the adductor longus. Clinical findings on X-ray will include subchondral erosive change, joint irregularity, and potential sclerosis around the anterior inferior pubis. As we've seen with other pathologies, finding on X-ray may not become apparent until up to 4 weeks after the onset of symptoms. I wanted to touch base on a unique series of X-rays that you may encounter in the orthopedic world, the flamingo view. So this series is used to assess pelvic instability and is used in the orthopedic trauma and sports medicine worlds. Essentially, the patient stands on one leg at a time and an AP pelvis image is taken. Pelvic instability can occur via a vertical subluxation or a symphyseal widening. So the diagnostic ranges are listed on this slide as well. Here you can clearly see the pelvic stability present with the patient stands on the right leg while the left leg is hanging. There is greater than 2 millimeters of vertical displacement on this X-ray, indicating instability about the pelvis. MRI is now considered the gold standard for diagnosing osteitis pubis since it provides a detailed view of the symphysis pubis, the immediate surrounding tissues, and the rest of the bony pelvis and hips. The most common findings in cases with less than 6 months duration is the presence of hyperintense signal on T2 weighted images within the symphysis and the adjacent parasymphyseal region. In cases that are more chronic or more than 6 months in duration, findings include subchondral sclerosis, subchondral resorption with bony irregularity, and osteophytosis. Here we see 2 different T2 weighted MR images. In the image on the left, there is bilateral diffuse symphyseal bone marrow edema and parasymphyseal edema. In the image on the right, there is hypertrophic bony and capsular changes at the pubic symphysis, as well as diffuse bilateral bone marrow edema. Here are 2 more series of MR images. The top row is an axial view of the pelvis. On the middle image of the top row, the black arrowhead represents a periosteal stripping of the pubic symphysis involving the adductor longus origin. The bottom row is a coronal view of the pelvis. Note the amount of bone marrow edema present, as well as the adductor longus tendinopathy indicated by the white arrowhead. As in several other orthopedic pathologies, bone scans are used less frequently, especially with the advancement of MR imaging. It's easy to spot the reuptake about the investigated area, but it's hard to assess the chronicity of the pathology on a bone scan. Musculoskeletal ultrasound is an up-and-coming imaging modality used in the orthopedic world since it is non-invasive, less expensive, and is more dynamic than some of the other imaging modalities. However, images depend largely on the skill of the operator, and there can be poor reproducibility of these images. So here's the picture of a normal pubic symphysis on an ultrasound. Here's a normal rectus abdominis attachment to the pubis that's indicated by the large white arrow. And here we see normal adductor tendon insertion onto the pubic tubercle. So the muscle bellies of the adductor longus and the adductor brevis are also labeled as well. Just remember that osteitis pubis is not typically a pathology that is seen in isolation. Typically, there will be concomitant enthesopathy of the adductor longus tendon at its origin at the pubis that will oftentimes accompany a bony stress change. There are some theories that suggest that the adductor tendinopathy or enthesopathy will go undiagnosed and then later develop into osteitis pubis. Here's a list of some of the differential diagnoses that may be mistaken for osteitis pubis or be seen in conjunction. This is not an exhaustive list, but rather something to keep in the back of your head when examining a patient with diffuse groin pain that you may or may not suspect has osteitis pubis. So here are my references. Thanks for listening, guys.